I'm Dr. Paul Shin. The topic of this presentation is imaging mimics of cancer and how these impact our cross-sectional and interventional radiology practice. Pseudolesions and mimics of cancer are a part of our routine practice. We encounter them daily. How we deal with them can be quite impactful, and to illustrate this, we're going to look at several case examples. Writing about mimics of cancer appears to be one of our favorite pastimes as academic radiologists, but that's probably with good reason because the challenge of mimics is something we deal with so often, and the mimics come in a variety of flavors. So pseudolesions can be, for example, physiologic phenomena like vascular shunts, focal fat deposition, or sparing. It can be caused by pseudo lung nodules from FDG clumping. It can be caused by brown fat uptake on a PET scan. And then benign or other tumors can mimic cancer. And if you think about it, LIRADs and some of our other algorithms for imaging are often predicated on distinguishing a particular entity like hepatocellular carcinoma from mimics of hepatocellular carcinoma. And of course, inflammatory or infectious abnormalities can simulate malignancy. And then we have the whole topic of incidentalomas, which intersects broadly with the topic of mimics. Of course, established cancer patients can also have superimposed non-malignant processes. And on the flip side, cancerous lesions can mimic benign disease. And in all of this, biopsy sometimes plays an essential role in clarifying the underlying etiology. The impact of pseudolesions is significant. If we have a wrong diagnosis, that can lead to a wrong treatment, a wrong or inappropriate procedure. These wrong treatments and procedures can lead to adverse events. These have economic consequences and ultimately, and most importantly, can cause patient suffering. So let's look at the case of a 52-year-old woman with metastatic myxoid liposarcoma. This was a patient that had a right thigh liposarcoma resected 10 years prior, followed by radiation therapy. Then 4 years later, she had a metastasis to the right paraspinal region at about the T8-9 level, and she underwent, over the years, many treatments. She now has an FDG-avid focus in the paraspinal region, and the oncologist reached out to me asking if I could biopsy this area. She warned me that there had been 2 prior non-diagnostic biopsies. On review, though, there were actually 3 prior non-diagnostic biopsies. And so she wondered also whether biopsy under MR guidance might be advantageous in this challenging case. Well, in looking at the MRI, there was this area of soft tissue thickening in the right paraspinal region, but there was really no focal discrete mass-like enhancement, and more importantly, this area had not changed in appearance over the past year. And in fact, the FDG uptake, as you'll see, was not in this location. It was posterior in the subcutaneous fat. These were the prior biopsies. One was done 2 years ago at the T8 level, one was done a year ago at the T10 level, and another 3 months ago at the T9 level. These all yielded things like chronic inflammation, fibrotic tissue, and degenerative changes. In reviewing the clinical history, it was very informative, and one of the most important things to glean from the history in this patient was the amount of radiation therapy she had in the right paraspinal region. In 2009, 50 gray. In 2013, 30 gray. In 2021, 35 gray. So a lot of radiation to this area in addition to surgery and chemo. On one of her CT scans after surgery, you can see that the radiated lung dropped into the resection bed of the right side of the spine. So the recent PET-CT that prompted the request for the biopsy is shown here. There's intense uptake along the right side of the spine. And if you look at the MIP image, it kind of has a linear configuration. And when you compare it to the PET scan from 6 months earlier and 11 months earlier, this activity is actually decreasing over time. On the other hand, there's this focus of intense uptake in the right paraspinal region more laterally that is getting more intense and is actually centered on a pocket of gas. And on the PET-CT report, this was thought possibly to be related to a biopsy, a recent biopsy. However, the biopsy was 3 months prior, that wouldn't account for gas in this location. And in fact, a CT scan from a few weeks before the biopsy showed that the gas was already there. So, this area of increasing uptake in the paraspinal soft tissues posterior to the rib requires explanation, and the gas. And so, in this patient with extensive prior radiation and surgery, we considered the possibility of herniated lung through a defect from surgery, but there was no continuity or contiguity with the lung. A bronchomediastinal paraspinal fistula might be considered. We couldn't see a direct communication with a bronchus, but presumably there could be air leaking from necrotic lung. Severe radiation necrosis alone, if it's an unusual case, might produce gas. Necrotic tumor can produce gas, and certainly if there's a superimposed infection, we might see gas. So the patient was treated empirically with a course of antibiotics. We advised against biopsy. There really wasn't a discrete mass in this location. 4 months later, a PET CT scan was obtained, and this gas collection has collapsed. There is a pancake-shaped flat area of intense FDG uptake, but on the CT image, again, there's really not much in the way of mass or mass effect. And so we think that this is essentially severe radiation necrosis. Maybe there was a superimposed infection as well that resolved, but it does not appear to be malignancy, and so we are continuing to follow this. The teaching points here are that prior non-diagnostic biopsy or biopsies should prompt a careful review before undertaking another biopsy. This patient already had 3 non-diagnostic biopsies. Clinical history, of course, is crucial. In this case, the very high radiation doses were an important consideration. And gas in an unexpected location has to be explained. I think that was crucial to the evaluation in this case. So we think this was FDG uptake related to an inflammation from radiation necrosis. We believe we have avoided a 4th non-diagnostic biopsy, and we'll just continue with imaging follow-up. The next case is a woman that had triple-negative invasive ductal breast cancer 3 years prior. The patient did not have nodal involvement or metastases and has been NED for the last 3 years, but she comes with low back pain now. The patient had a restaging CT scan. There was a presacral abnormality that was read as etiology unclear, may represent bilateral Tarlov cysts, metastatic focus possible but unusual. MRI would likely be helpful for further evaluation. No mention of the fat within this mass and no differential diagnosis for a fatty containing presacral mass. On the MRI, we see this presacral abnormality read as mildly enhancing presacral mass, nonspecific, may include fat, well, at least they mention fat, no associated underlying bone abnormality, neoplastic process remains a diagnostic consideration, PET CT recommended for further evaluation. So again, no differential for a fat-containing presacral mass. Now they're recommending another test. So the PET CT was done. There is low-level FDG uptake within the non-fatty components of this mass. The PET scan was read as no convincing evidence of FDG-avid metastatic disease. That's good. A slowly growing, predominantly fat density mass with faint FDG uptake in the presacral region is indeterminate. Again, no differential given for a fat-containing presacral mass. So I was asked to biopsy this because they were concerned that this could be a metastasis. And, in reviewing the imaging, I also found this PET CT from just over 3 years prior, and there was no change in this abnormality. So I told the oncologist that this is almost certainly a benign mass, likely one of the following: extramedullary hematopoiesis, although the patient had no underlying anemia or marrow disorder, myelolipoma, pelvic lipomatosis, teratoma, and then liposarcoma, very unlikely given the stability of over 3 years. So I advised routine restaging, follow-up, and no biopsy. However, because of the way the prior reports were read, there was quite a bit of anxiety about this lesion and the fact that the patient seemed to have symptoms. And so the oncologist and the patient really wanted to proceed with biopsy, even though they knew that this was likely benign. We did the biopsy. It was not really accessible posteriorly unless you want to drill through bone, which we didn't. And so instead, we used our 3D printed compression device to displace the bowel and steer a biopsy needle into this mass. You can see that we sampled different parts of this mass, and the path came back fibroadipose tissue with small lymphocytes, no evidence of carcinoma. And so we think this was pelvic lipomatosis. On follow up, actually, the orthopedic surgeon who saw her felt that her pain was really not so much low back as it was right hip. He felt that she had a bursitis trochanteritis of the right hip. So the teaching points here are that imaging features and stability all but confirmed the benign nature of this mimic of metastasis, and biopsy was not necessary. But it does highlight how important the wording of our reports is, and then sometimes biopsy is still needed to manage referring physician and/or patient anxiety. Another patient, an 82-year-old man with a history of chronic kidney disease. His EGFR was 50. Notably, he had a renal cell carcinoma 20 years before that was managed with a right nephrectomy, and he remained NED ever since. He now presents with an enhancing solid left renal mass. And so, of course, the question is this RCC, renal cell carcinoma? The CT scan is shown here. There is this inhomogeneously hypervascular mass of the renal sinus region, and it was read as may represent a primary or metastatic clear cell renal cell carcinoma. They also noted some sub-centimeter retroperitoneal lymph nodes indeterminate. And on the coronal image, you can also see here's the hypervascular mass with these little internal pockets of non-enhancement. So I biopsied this, obtained a core biopsy, and the pathology came back anastomosing hemangioma, no evidence of malignancy. This was an anastomosing hemangioma mimicking RCC. End of story, right? Well, not so fast. So 8 months later, a CT scan was obtained in follow-up, and it was read as follows: enlarging left lower pole heterogeneously enhancing mass, also enlarging para-aortic lymph nodes. Biopsy had been interpreted as a sclerosing hemangioma, a very unusual diagnosis in the renal sinus fat. Subsequent enlargement is concerning for renal cell primary, likely given the patient has a history of right renal cell carcinoma. Recommend urology consult and biopsy of the left para-aortic lymph nodes. Well, of course, this wasn't a sclerosing hemangioma. This was an anastomosing hemangioma. The enlarging mass was 4 millimeters larger, so that doesn't really tell you much. Benign lesions can grow a little bit, malignant lesions can grow a little bit. And the lymph nodes were just very few, and the largest was still less than a centimeter in size. But the biopsy was done, and one of my colleagues did a beautiful job of getting a core biopsy of the largest of the tiny lymph nodes, and the path came back benign lymph node. Well, the patient went back to the urologist. The urologist felt that a diagnosis of anastomosing hemangioma is quite unusual, raises the possibility of false negative biopsy. Enlarging para-aortic lymph node was benign on biopsy. I continue to harbor a high suspicion for an underlying malignancy. And in fact, he discussed it with the patient and recommended SBRT, radiation therapy, and sent him to the radiation oncologist. So the radiation oncologist saw the patient and agreed that this was concerning. Fortunately, he contacted me and requested fiducials, gold seed placements, to facilitate SBRT. And of course, keep in mind, this is a patient with a solitary kidney, and he does have chronic renal disease. His EGFR is already less than 50. So they're going to radiate this kidney for a potentially benign lesion. So I had this discussion with the referring physicians, explained that I think this is really just a benign anastomosing hemangioma. We can just watch it. But they were very concerned, and so I said, well, I tell you what, when I place the gold seeds for SBRT, why don't I biopsy the mass again? And they agreed. I biopsied it again, and of course it confirmed anastomosing hemangioma. I sampled a few areas. Well, anastomosing hemangioma is a relatively recently described entity in 2009, but when it does occur, it often occurs in or adjacent to the kidney. and it can occur in the renal sinus region, but it can also involve other areas listed here. Patients that have renal anastomosing hemangiomas often have end-stage renal disease. Our patient had chronic renal disease. It usually occurs in the renal parenchyma, but it can be in the sinuses or in the perirenal tissues, and it often mimics a hypervascular renal cell carcinoma or angiomyolipoma. They can be multiple bilateral. They're variable in size. They're usually asymptomatic but can cause symptoms. And under the microscope, they resemble angiosarcoma but without the malignant features, and they have these characteristic communications between these small vascular spaces. Importantly, they have uniformly a benign clinical course. Only observation is needed. Interestingly, most of the reported cases in the literature were resected surgically because they didn't know what they were. One of the largest reported series came from our institution, Brigham and Women's. It was 32 cases of anastomosing hemangioma, 5 that had imaging. The lesions tend to be well circumscribed, mildly hyperdense on non-contrast CT. They enhance heterogeneously and avidly, and the enhancement persists into the late phase if obtained. You may also observe partial filling in on late phase. They can be diagnosed, importantly, with core needle biopsy. This is sort of the crucial thing, is these can be diagnosed on a core needle biopsy, and that may obviate the need for surgery. So this was a companion case of an anastomosing hemangioma we saw last year in the liver. You can see on T2, very T2 bright. And then with contrast, there's avid enhancement that persists into the late phase. There might even be a little bit of progressive enhancement in the late phase. And some of these anastomosing hemangiomas are associated with a concurrent malignant tumor. And in this case, just inferior to this, there was a LRM lesion that was not arterial phase hyperenhancing. And when that was biopsied, it turned out to be HCC. So interestingly, occasionally an anastomosing hemangioma is seen next to a malignant tumor. So the teaching points here are that anastomosing hemangioma can mimic almost any hypervascular tumor. The imaging features may be suggestive of anastomosing hemangioma, but are often not diagnostic. And so ultimately, percutaneous image-guided core biopsy can establish the diagnosis and thus avoid unnecessary surgery, radiation, or other intervention. And finally, sometimes it takes 2 diagnostic biopsies to stop a train. The next case is a 43-year-old man who had a recent left adrenalectomy 4 months previously for a low-grade leiomyosarcoma of the adrenal. This CT scan showed a splenic lesion, and understandably that raised concern of a metastasis. We did a biopsy. After we got the core biopsy from the mass, we cauterized the tract using RF tract cautery, and the pathology came back splenic parenchyma with scarring and florid lymphohistiocytic inflammation. So we were confident that we were in the lesion, and so we felt that this was benign, and the patient was followed. But then on follow-up imaging, the lesion was mildly FDG avid on PET, and the MRI is shown along the bottom here, and it was read as enlarging 2.6 centimeter subcapsular splenic mass without characteristically benign features, most likely metastasis. So we'll come back to that. Now, because this patient had no other evidence of metastatic disease, but he was a young person, and obviously if this was a met, it would be of crucial importance to his management, we re-biopsied it, again using RF tract cautery to reduce risk of bleeding. And this time the path came back sclerosing angiomatoid nodular transformation of spleen, a SANT of the spleen. Now these are usually solitary splenic lesions. On ultrasound, they tend to be hypoechoic. They enhance with contrast. On non-contrast CT, they are usually hypodense. And then with MRI, they tend to be T2 hypointense. But with contrast, they show peripheral enhancement, kind of a rind of peripheral enhancement with a central stellate hypoenhancing region, as seen in our case. and then the enhancing area persists, and sometimes there's even some centripetal filling in of contrast, as seen in our case on the bottom. And also, FDG PET scans may show mild to moderate FDG uptake in a SANT, so that's not surprising. So I think the lessons here are that the imaging features actually were suggestive of SANT, but probably not diagnostic. So biopsy may be required in a case like this for confirmation, particularly if it would have a strong impact on management. And clearly, in this person with no other evidence of recurrence or metastatic disease, it would be very impactful if it was a metastasis. The other thing I would point out is that a specific benign pathologic diagnosis is often very helpful. The first path diagnosis, although benign, was not specific. The second one, though, confirming SANT, gave a lot more assurance that we were dealing with a benign lesion. A 72-year-old man with end-stage renal disease, his EGFR was only 7, was being considered for renal transplant, a living-related donor. He had undergone a left partial nephrectomy 7 years earlier for a benign oncocytoma. But now he has an enlarging right renal mass amongst many cysts and hemorrhagic cysts of the right kidney. So the question was, does he have a renal cell carcinoma that would impact his consideration for renal transplant? He couldn't get IV contrast for his MRI scan, but the non-contrast MR is shown here, T1 weighted images on the left, T2 on the right. There was a lesion at the upper pole that was hypo on T1, inhomogeneously hyper on T2. It was read as likely a cyst based on stability over a period of about 5 years, and less likely neoplasm. And then in the lower right kidney, there's a lesion that was felt to have grown significantly over the last 5 years and was thought concerning for possible renal cell carcinoma. And the recommendation was for contrast-enhanced ultrasound for this lesion. And then at the lower pole, a very exophytic lesion projecting anteromedially is very T1 bright and very T2 dark. And it was read as likely hemorrhagic cyst. So, faced with this MR report and the need to determine whether or not he has renal cell carcinoma, we decided to do contrast-enhanced ultrasound. And it turns out all 3 of these lesions enhanced. So all 3 were solid enhancing masses, including the exophytic lower pole lesion. So then, which lesion do you biopsy? The truth is, any of these lesions could have been a renal cell carcinoma, and if any of them were renal cell carcinoma, that would require management before consideration of transplant. So we biopsied all 3 in one setting. The top lesion that was thought to be a cyst, although can't rule out neoplasm, was a benign oncocytoma. So oncocytoma mimicking possible renal cell carcinoma. The lesion at the lower right kidney laterally that was thought suspicious for renal cell carcinoma was a benign oncocytoma, again mimicking renal cell carcinoma. And the lower pole exophytic lesion that was thought to be most likely a benign hemorrhagic cyst turned out to be papillary renal cell carcinoma, WHO grade 3 of 4. So the teaching points here were that, number one, contrast-enhanced ultrasound is a great problem solver for patients who can't get IV contrast and who have liver masses or kidney masses and so on. The second point is that sometimes biopsy of multiple masses is essential for appropriate management decisions. So this patient subsequently had a right nephrectomy because of his renal cell carcinoma. The resection specimen confirmed the biopsy results. And then subsequently the patient underwent living-related donor kidney transplant. The last case I want to show you is one that I encountered recently at a major interventional radiology conference. I participated on a panel where we were tasked with presenting cases where we had complications so that the audience could learn from our complications. And one of the co-presenters showed a case like this. It was a young man with congenital heart disease and cardiac cirrhosis who had a lesion at the liver dome in a subcapsular location. It looked just like this, although I don't have his images. It was about a 2.5 centimeter arterial phase hyperenhancing mass in the dome under the capsule that showed definite washout. So the presenter said that this was reviewed at their liver tumor board. It was considered LIRADS 5, and the recommendation was image guided radiofrequency ablation. So that was done. The patient underwent RFA, but left the hospital, unfortunately, AMA, only to come back a couple days later in shock, and he died from his bleeding complications. The presenter was showing this case as a technical discussion of how one can avoid bleeding complications from an ablation procedure of a liver lesion in a subcapsular location. And so I asked the speaker if a biopsy had been performed, and he seemed surprised. In fact, he said, no, it was an LR5, and he polled the audience, would anybody here have biopsied an LR5 lesion before ablating it? And there wasn't much response. So I said, well, we don't apply LIRADS in patients with vascular etiologies of cirrhosis. It's not considered an appropriate population to use LIRADS because these patients have a high incidence of benign hypervascular lesions such as regenerative nodules or focal nodular hyperplasia, and these can mimic HCC, and so LIRADS is not reliable in making this diagnosis. The patient apparently did not undergo autopsy, so we'll never know what actually the path was. But it just makes the point that mimics and how we handle them have consequences. Wrong procedures can result, adverse events can result, even fatal adverse events. In conclusion, mimics of cancer are encountered daily in our interventional practices. Recognizing potential mimics is very impactful. Getting past our initial impressions may require a close look and correlation with patient history, review of old imaging studies and procedures, and up-to-date knowledge. Image-guided biopsy is often essential in sorting out the truth regarding these mimics of cancer. And I would like to leave you with one final thought, which is that strong diagnostic imaging skills and their thoughtful application make for better interventional radiology and interventional radiologists.